And thank you, chairpersons and the organizers who have invited me to talk on a very important virus, often neglected, but there's so much complications. So I bring to you all greetings from Institute of Liver and Biliary Sciences, which is there in New Delhi. It's a dedicated liver and transplant center. I'll be very brief, knowing that not many people are virologists and microbiologists. So just about a few words, lines about CMV. It is the largest, like cytomegalo. So cells are big, belongs to herpes viridae family. It is universally present globally, everywhere, almost all the sites in the name a site and CMV is there. And though it was first isolated from salivary glands, and then it is a unique, like other viruses of the herpes family, it finds latency and they get derived into CD14 positive, the monocyte precursor cells, leukocytes, endothelial cells. So almost all the linings, all the cells, you will have CMV present as latent infection. The seroprevalence, when we talk about its exposure and one-time infection occurrence, it's about to the tune of 95 to 100% in developing countries. So like India, so like 95 to 100% chances we have acquired and somewhere in any of our lining, the virus is lying latently. It is just 50 to 60% in developed countries. So the problem in developed countries of primary infection, and they talk a lot, but for our country, it is more of the reactivation of CMV. And like with the knowledge we have got in COVID, that it is not only the active virus replication which matters in the disease, it is the cytokine plethora, it is the other inflammatory processes it stimulates, which add on to the disease, the outcome of the clinical disease scenario. And CMV is one virus which is very less studied because it is also present everywhere. Apart from the direct effect, the indirectly it brings a lot of changes in the human system. So many disease outcomes are there which should be studied and discovered along with CMV. So how it finds latency, mostly saliva, it is shed in saliva, tears, urine, stool, breast milk, most of the body secretions, goes in, gets at the age of 6 to 7 years, lines your respiratory tract and GI tract, the two important sites. And primary infection usually seen in young adults or children is asymptomatic, or it can be febrile, or it is infectious mononucleosis like syndrome, which is a self-limited course, but it finds latency, which I have told you in most of the cells. The reactivation of CMV is now very well studied. Often, many things are not known under this area, but it is not only to do with the immunosuppression, it has to do with other cellular differentiation and inflammation. Basically, the release of TNF alpha, which goes and binds to the receptor and activates NF kappa B, which has been found to be the most important factor, which activates the PP65 antigen of the CMV, it activates. So unlike it was thought that it is a virus post-immunosuppression, transplant associated, there are a lot of other inflammatory diseases in the body which stimulate CMV and it replicates. And many, as I said, a lot of work needs to be done. So I'll diagnose, the topic which was given was diagnostic challenges. So I've picked up one or few examples, may not have done justice, but where the challenges do come. So one of the important is an asymptomatic, immunocompetent individual when it presents as infectious mononucleosis. So I said mostly it is resolving self-limiting, but infectious mononucleosis, which is typically seen in young adults, 20 to 30 years, you'll have PUO, prolonged fever, history of myalgia, may have adenopathy, lymphadenopathy, pharyngitis, but this type of IM presentation is more with EBV associated, not with CMV. CMV is usually PUO. So you'll often have in your lab investigations of PUO or fever of unknown origin. And for the hematologist, you'll have lymphocytosis with abnormal atypical lymphocytes, which are characteristics, which give you a hint that it could be CMV and or EBV. So CMV here, the classical, so in the end, I'll tell you what are the diagnostic algorithm available, but CMV serology and especially IgM assays, which are available, they become diagnostic here. Although the confusion comes with Epstein-Barr virus, we also have published, I've not shown the cross-reactive antibodies to EBV and CMV. But however, even if you reach a diagnosis of CMV, the clinical management right now for the control of IM is not giving any specific antivirals. So you can actually just come to a diagnostic etiology of CMV by just simply doing a CMV serology and atypical lymphocytes in your interest. Now, sometimes the difficulty comes when the infectious mononucleosis does not present as typical infectious mononucleosis. And very often when we come from the liver center, the type of presentation is as acute viral sporadic hepatitis. So for the last 15 years, we've seen many of cases when the patient walks in, the clinician suspects only abnormal deranged liver function test. Jaundice may be there, may not be there, and the fever as the cause of presentation. Now, here comes CMV, the role of CMV as a non-hepatotropic insult to the liver. They cause immune-mediated. More so, it is the collateral T cell damage, activation and damage. So what happens is that when you acquire infection in your early childhood, you stimulate your T cell and CD4, CD8 T cell responses, and those memory cells, they reside in your bone marrow. Now, few of them are also go and it becomes latent in the endothelial lining in other monocytes, which are there inside your hepatic cell, liver milieu. Now, once you have, because of any stress, the reactivation happening, so the destruction which is happening in the liver is not the T cells, CD8 T cells, they get activated, they start damaging the liver. Also, the destruction happening is more in terms of the liver cell damage and results into an abnormal acute sporadic viral hepatitis, which we call as a collateral damage caused by the T cell activation. Endothelial cells in the liver also get activated and they cause damage. So the diagnosis here, because the patient is immunocompetent, so once you rule out all hepatotropic damages, you do CMV IgM and it usually comes out to be positive. Histopathology, because it's an acute liver flare, is not recommended because that becomes invasive liver biopsy. So CMV IgM. And we did a study, and surprisingly, I wanted to share with you that we took all the causes of sporadic AVH and ACLF and 10% a cause associated with CMV and EBV, where A to E other viruses were negative. In 10%, we found attributable cause by CMV and EBV. So this is one diagnostic challenge sometimes that we keep on repeating A to E, and we start looking for other causes of hepatitis where CMV is the one. Again, nothing to be done. It is self-control resolving, so it will resolve on its own. And just by CMV IgM positive, you might have CMV DNA in blood also. Nothing to be done. Only the patient, it will be self-limiting within 4 to 5 days or a week at the most. Another important confusing area is very often when you have critically ill patients. So from the ICUs, you will often, if they cannot find any etiology. Now, because this is a double-edged sword. So having so many diagnostic algorithms available and clinicians knowing about it, sometimes it's difficult for lab people to convince them and tell them what is the significance of this diagnosis. So now, like in our institute, we have the whole list of 25 to 26 molecular pathogens available. So they tick all the known causes in a critically ill, and when the patient is deteriorating, they also ask for, in an immunocompetent person, they ask for CMV, and often CMV IgM or CMV DNA comes out positive. Now what to do? So that is what, because the virus will reactivate whenever the host is under stress. I showed you there is a TNF alpha, the entire pathway. You might get IgM as a or a DNA as a positive. Now, should you report? You should or not report. If it is just a silent reactivation, then you should report it, that it could be just a reactivation, but you should try to look for a CMV disease, which I'll tell you, which is associated with either invasive tissue disease, or there is a fever, there is a pancytopenia or lymphopenia, which is associated with it. And you really feel that giving on to an antiviral specific for CMV can help, then you might report. But not much is known. And then you know that the other infectious etiology is not there and that critically ill, which is difficult. And because the clinical outcome needs to be assessed, There is no criteria, there is no algorithm, unfortunately, available where how you should do the reporting and what should be the outcome, if even if you report whether the clinicians are going to treat or not. So it has been associated with quite a strength of association, like when the patient is on mechanical ventilation or there is a sepsis, CMV often reactivates. Then if the patient is on prolonged corticosteroid or blood transfusion multiple sets, then there is a weak association of occurrence of CMV. Again, since we are in an institute where a lot of critically ill cirrhotics are there, we try to look into that does there any association. So we did a cross longitudinal study of critically ill cirrhotics who were there in our liver coma ICU, and we did find that quite a chunk of them in which the reactivation of CMV occurs. But fortunately, it was not associated with any adverse outcome or the need for a mechanical ventilation. So it can be, and especially by the seventh day, if the seventh day of ICU admission, there's a maximum reactivation of CMV. So this is another aspect. I think more literature needs to come out, whether these silent reactivation in an immunocompetent cirrhotics or ICU patient should be reported or not. So this was a talk about CMV and immunocompetent. What is the literature? So IM, I told you, is an important component. Sometimes infectious mononucleosis presenting as sporadic viral hepatitis is important. And in certain critically ill, you may get transient occurrence of CMV, but whether it should be reported, the consensus needs to come out. But unfortunately, it is not there. In immunocompromised, yes, the role of CMV is very well established. Solid organ transplants, hematopoietic cell transplantation, and HIV/AIDS. So CMV, as I told you, it has direct effects. It has also indirect effects. In solid organ transplants, it's more with febrile illness of infection and disease with leukopenia. Site involvement is more with stem cell transplantation like pneumonitis and gastric lining like gastritis and esophagitis, while in HIV/AIDS, it's characteristically present as retinitis and the site, that is the direct invasive CMV disease. Apart from them, in most of them, the indirect effects because of the cytokine chloride effects is because of the impaired graft function, because of, and it also accelerates other opportunistic fungal bacteria, even Epstein-Barr virus infection, and leads to eventually the graft failure. So CMV in transplant, it's the most common pathogen. Everybody looks for it. It can be asymptomatic anemia or may progress to tissue invasive disease. So we define CMV infection when it is just a mere presence of either the antigen or nucleic acid, that is the anemia. It is a disease when there is attributable symptoms. Now, disease is 60 to 70% chance called as a syndrome when it is just causing the blood cell abnormality in terms of leukopenia, neutropenia, or thrombocytopenia. There is no tissue or specific site involvement. And in 20 to 30%, it may lead to tissue invasive, more so in, as I told you, bone marrow transplant and HIV, less in solid organ transplant, the tissue invasive disease. And gold standard for tissue invasive is histopathology or nucleic acids from the site of the tissue. Now, what are the risks of acquiring CMV post solid organ transplant? The risk is always determined based upon the donor and recipient pre-transplant serostatus. As I told you, we are 95 to 100%. So mostly in the category 2, that is the intermediate risk, where both the donor and recipient is positive or recipient is positive. So mostly the reactivation will occur. So in high risk is when donor is positive and recipient has never had an exposure, and the chances of primary CMV infection. Very low risk through blood transfusion, because I told you it's there in all the leukocytes, can be there in when both the donor and recipients are negative. Now, in the order of the organ of transplantation, the lung and small bowel, of course, because respiratory tract lining and GI lining is there, followed by kidney and then liver of CMV, and the type of immunosuppression, the dose, duration, and type of immunosuppressive agents, the risk of CMV changes. So a latent CMV infection gets activated because of so many factors. Directly, the CMV starts replicating and causes a disease, especially in the GI, respiratory tracts, and pneumonitis, gastritis. It can be simple syndrome. There is just a fever and abnormal blood found, or it can be an anorgan disease. The indirect effects can be, as I have mentioned to you, the co-infections and other graft rejection episodes. How do we diagnose post-organ transplant? So pre-transplant evaluation, you have to categorize the patient with the risk, and depending upon the risk, your post-transplant suspect goes. So if it is a high risk, then definitely for a primary infection we are looking, or if it is a low risk or intermediate, we are looking, intermediate risk, we're looking for a reactivation. So serology definitely has got no role following transplant because we know they are on immunosuppression. So it will be a false negative. So we do not depend upon IgM or IgG assays. And it has viral culture and otherwise the rapid viral culture like shell viral cultures. And all these also have proven to be no role. Now the guidelines do not recommend them because they are tedious, labor intensive, and they have very, very low sensitivity. So it is the quantitative nucleic acid test, that is the CMV DNA quantitative PCR, which has become the cornerstone of diagnosing. It is preferred. There are studies, a lot of literature available, whether PP65 antigenemia is a better test or quantitative NAT. And universally, quantitative NAT has been adopted into all the guidelines because PP65 has its labor intensive. You have to store the blood, the same day processing, specificity, sensitivity, and person-to-person variability. Now, earlier we used to struggle 10 years back with reporting, and all transplant centers were told that do a CMV DNA test post-transplant on the same machine, same principle, same kit. But because that time we were reporting in copies per ml, and that is why the earlier guidelines, you'll see that they say that it should be done on the same test, same kit when you're following up a patient. But this problem has gone because of the introduction of WHO standard, which has recently come. And now all results mandatorily have to be reported in international units per ml. So even if you buy a kit and they are giving you in copies, tell them the conversion factor, because this is now like hepatitis B, C, HIV, all it is universal and it should be comparable across platforms, across kits. Reporting should be in international units per ml. Now, the changes do occur, but what are the significant changes in a viral load? So you have to do repeated. So one time detecting and one time testing of a CMV DNA PCR post-transplant will not be of any use. You have to show at least a change in 0.5 log 10 value, which should be considered as a significant. So each transplant center needs to, I'll show you, establish their own guideline and a threshold, how frequent we're going to do, and especially so in a highly seropositive population like ours, because what all guidelines are available are American, where the preventive aspect is more because of the primary infection. But here we have to look for the reactivation. I'll be showing you what we have done in our center. So tissue invasive disease, when you have characteristic involvement, whether it is pneumonia or it is a GI, so you have to show replication in tissue. You can do by immunohistochemistry or histopathology, which is the gold standard. But now quantitative NAT even has come out to be an important, and is people are taking onto it. So very, very, so identifying the doing a blood PCR, and if it is more than 5 log value in a BAL or in a blood can, and there are silent localizing signs and symptoms of infection, that can be reported and should be considered as significant, especially in case of lung tract involvement or respiratory involvement and GI tract involvement. Immune monitoring, this is another new test which is coming up, where people are trying to look for T cell responses, especially the interferon gamma stimulated responses. And there are kits commercially available like quantiferon CMV assay, where they have tried to do pre-transplant evaluation and try to look the effect of this on the post-transplant occurrence of CMV. We also published recently, but we found that doing a pre-transplant evaluation, cell-mediated immune responses, post-transplant reactivation occurrence was seen less in those who were positive with pre-transplant CMI. When you put them on specific antiviral, the clearance rate was faster, and the amount of the viral load, the burden of the viral load in those who have pre-transplant CMI positivity. So this is one future marker, which I think still not, it has not come up. There's not enough of evidence that it should be incorporated into a guideline that it should be done in pre-transplant recipient settings, but it does have a role. So as I told you that each center should sit with the surgeons and should sit with the kind of population you are taking care of, that how frequent monitoring we need to do, when we should start doing the monitoring, and what should be our threshold of reporting and what. So in our center, because the liver transplant, you do not give prophylaxis unlike the renal transplant, you give preemptive management. So preemptively testing for CMV DNA is very, very important. So in our center, we start testing for CMV DNA first week post-transplant onwards. Until 4 week, first month we do weekly, and then monthly for about 3 months. And after that, as and when the patient requires a testing, that we do. And our center cutoff, we have kept it as 500 international units per ml. Above that, we report. Less than that, we just report less than 500, not even negative, but less than 500. The protocol our surgeons follow is that if it is 500 or less than 500, they do not do anything. They just, we raise an alarm and they are aware. 500,000, they just try to reduce the immunosuppression. But more than 5,000, we definitely give them an advice to start immediately on specific CMV antiviral. But again, depends a lot upon the patient and categories if they suspect. So the surgeon's decision is final. Sometimes with 500 to 1,000 also, they prefer to put a patient on the antiviral, depends upon the surgeon's clinical decision. Now you should stop the treatment. Then once you put the patient on treatment, then weekly you should monitor for CMV negativity, and 2 DNA, which are negative report from your lab, 15 days apart, then they should stop the antiviral therapy. This is what we do. So, I'm sorry for the interruption, but you know, running late. Okay, sir. I'll be done. Yeah. So we normally, we have seen that the most of the CMV infections are occurring in the first week. So this is like initial studies that you have to do and guide that how frequent you have to do. And so we, in our center, we are doing it weekly monitoring. Another interesting, so this is about post-transplant CMV. Another important is the GI tract, as I said, colitis and in inflammatory bowel disease, the occurrence of CMV, whether it is a bystander, should you report, should you not report? Then especially in steroid resistance, the occurrence of CMV is very, very high. But although histopathology is the gold standard, but there are limitations. So now most of the labs are doing CMV DNA PCR from the biopsy. But mind that you have to collect biopsy and parallel blood sample and show the presence. Either you show more than 3 log copies in the biopsy, or you show that blood and there is a difference of more than 250 in both the samples, then you should report. We also did few studies and found that a cutoff of 2.5 log copies in tissue biopsy is a good to tell you about the involvement as a true pathogen of CMV, steroid resistant IBD. Congenital CMV, I think it's a whole new area on its own. I'm not going to because of the paucity of time. But yes, in West now, the guidelines in Europe, Australia have come up that they have started screening for antenatal for the congenital CMV. The approach they use is testing for antenatal mothers for IgG, IgM, IgM positive, then IgG avidity low, because we are here going to target primary infection, not the reactivation. And then they go for amniotic fluid DNA PCR or in vitro sampling PCRs and other, these are the recommendations for congenital CMV. So now in a nutshell, these are the diagnostic clinical scenarios where challenges can come. So CMV can be diagnosed, as I told you, shown you by culture, by microscopy, indirect serology, and molecular. Molecular is now going to be the future test. Everybody is in all the clinical scenarios, CMV DNA PCRs and quantitative nucleic acid testing. Quantitative CMV DNA PCRs have come up. Although there are certain limitations at this point, I like to say, because you do not know that which population, what is the threshold value. As I said, what is the normal immunocompetent CMV DNA PCR in a person, or a person who is cirrhotic, what is the normal? Does it get reactivated, or this is a normal level? So all these thresholds and different type of population needs to be established, and then only we should come up with these guidelines and algorithms. They are all lacking, and it should be, this is a very important area. So I summarize that it is universal CMV infection. It's difficult to diagnose. A lot of clinical acumen and correlation is needed because of vast colonization. Diagnose different patient profiles, there are issues. So careful selection of test and result interpretation. Apart from post-transplant, other disease scenario, the information and guidelines are lacking. But fortunately now with the availability of good assays for CMV, DNA, PCR and international unit, it is going to be an important step forward in understanding this disease. Thank you.